We are live in 3, 2, 1. We are live now. You can start, ma'am.
Yeah, thank you. So first presentation will be done by me. I'm Dr. Prashanti, pediatric neurologist and epileptologist from Rainbow Hospital. This is about oxcarbamazepine in drug refractory epilepsy. So case 1, 5 and 9-month-old boy, apparently well, presented with episodes of inappropriate laughing, lasting for few months since past 1 month. Episodes.
Sorry, ma'am, to interrupt you in between. Can you please put your presentation in presentation mode?
How to do that? Not sure.
At the right hand side bottom, there would be in presentation mode.
And that is in the PPT. This is actually on the screen it is coming in a presentation mode, but the laptop it is coming in a different mode.
Okay. Can you just turn on it once again? Put it in the presentation mode.
I think.
Yeah.
Okay. Yeah, here it is the screen.
This is good to go, ma'am.
Okay, now here there is a issue. Okay, fine. This is okay. This is okay. Yeah. So 5 years, 9 months old boy, apparently well, presented with episode of inappropriate laughing lasting for few minutes since past 1 month. Daily episodes 4 to 5 per day. He was started on levetiracetam. There was no decrease in the frequency of episodes. So this was the only complaint. Birth history is normal, perinatal period. Developmentally, he was appropriate development for age. Family history is first born to non-consanguineously married couple. There's no family history of epilepsy. There's no change in behavior or speech or sleep-wake cycle. There's no history of fever in the past 1 month. So examination was normal. His cranial conscious oriented speech was normal. Cranial nerves, motor, everything was normal. So clinically thought of gelastic seizures, or either it is a behavioral disturbance or autoimmune disorders. So just as an overview of causes of pathological laughing and crying, this is actually in adults where there is amyotrophic lateral sclerosis, multiple system atrophy, cerebrovascular diseases. They present initially with episodes of giggling, followed by they go into a proper stroke. And multiple sclerosis can also present, Parkinson's disease, traumatic brain injury affecting the frontal cingulate areas and temporal areas can present, then dementia, migraine, progressive nuclear palsy. So all of these are predominantly adult disorders and rare in a pediatric age group. So with this is the episode. So he is fine right now, just crawling. Now he feels abnormality, gets up and looks around, and he starts smiling and starts laughing. He's following commands during the event, but he's unable to stop laughing. These episodes, he does not remember what has happened after the event. But he interacts during the event. So this is the at admission. These events used to last for 2 to 3 minutes. So first thing is we did EEG. So now he has recovered. No, sir. In this particular event, no. Both hands he was using equal. In this. History-wise, they don't give any automatisms. Later on seizure evaluation, we have lateral left hand posturing he's having after treatment was started. But in the at the presentation, no lateralization features, no. Preserved during the event. He doesn't remember the event, but he says few words. He speaks, yes. The elastic seizures. In this particular event which we presented, no, sir. No. So non-dominant hemisphere we can think of. But if it is a very focal gelastic seizure, don't. But yes, if the speech is preserved, we have to think of non-dominant. But the consciousness has to get involved. I mean, all those temporal depends upon the temporal lobe. So could be non-dominant hemisphere. He is a right-handed child. Yes, it can be frontal. I mean, differentials for gelastic seizures is hypothalamic hematoma, then frontal polar regions, temporal polar region, cingulate for frontal cingulate, and temporal. Some case reports are there for the temporal also. This is the interictal EEG showing spikes in bilateral frontal, frontotemporal regions also, predominantly frontal. Slightly more higher amplitude on right side, plus minus. So in sleep, we can see some runs of activity. Some right hemispheric dominance is there. Just to say that his background is normal, sleep structures are normal, awake background is also normal. This is the event ictal record during this particular seizure. So event starts off at this marker, blue point. It's very smart. Just 1 second, sorry. Yeah. So this blue marker where it is there is diffuse attenuation and fast activity. That is the onset of the clinical event. So before the event, there is this runs of spikes. Probably there is a right-sided spikes starting first. This fast activity over here, which is probably evolving. And then there is a left-sided fast activity, which evolves into bilateral frontal spikes, frontal dominant spikes, and then goes into diffuse attenuation like this. And this is when he starts having the seizure. And it evolves in frequency and amplitude. Yes, evolving slightly better on the right. A lot of artifacts are also there on the right hemisphere. So probably evolving better on the right hemisphere. So this is the at the end of the seizure. There is probably some right hemispheric slowing compared to the left. But only for a few seconds it lasts. After that it normalizes. So MRI brain from EEG, because it is bilateral frontal, right dominance. Yeah, right dominance. Sometimes it is generalized. Sometimes you will see that right onset. No. It was right-sided. So right-sided, frontal, predominant. So can be cingulate. This is right more than left, frontal. Hypothalamic hematoma also can have similar EEG picture. lateralizing will not be there, but it is a generalized discharge, can be frontal dominant. Sometimes it can lateralize, rarely. But here, because we had plus minus, some of them had, some of them didn't have. Possibilities we can't rule it out completely. So with this, so it is a gelastic seizures. Probably I would put frontal cingulate, then hypothalamic hematoma, and other areas later on. So MRI was done, which was normal, no hypothalamic hematoma. Cingulate was asked to look at, not reported any FCD, focal cortical dysplasia, anywhere, temporal or any other region, and specifically looked at cingulate. So with this, they thought of autoimmune also as a possibility. So CSF analysis was done, which was normal. HSP PCR for mood changes and all this was done, which was negative. Autoimmune profile was sent, and he was started on multiple antiepileptics, lacosamide, levetiracetam, valproate, perampanel, one after the other. And then we suspecting autoimmune PET scan was done, which was reported as bilateral frontal hypometabolism. But if we look closely, I think there is some right-sided increase. So probably still lateralizing to right side. But because of the bilateral frontal hypometabolism, autoimmune was still kept as a possibility. Still ganglia are fine, sir. Overall, the rest of the thing looks hyper, but I think that's just the windowing problem. So except for the frontal and cerebellar hypometabolism is there. Rest of the structures are normal. So he was started on steroids, thinking of autoimmune, because multiple antiepileptics not responding. MRA was reported normal, PET is showing hypometabolism, and there was bilateral rhythm. So thought of SRSE evolving or some other autoimmune pathology, and started on steroids. And he was also given tocilizumab. Then CSF autoimmune profile came negative. GAD65 antibody was sent. Reason for that is this one, there is a case report where they have reported gelastic seizures. And EEG showed temporal lobe spikes in that particular patient, and he was positive for anti-GAD65 antibodies. It was in a 44-year-old female with renal end-stage renal disease. So after giving steroids, the child became that person became seizure-free. So with this background, they thought of GAD65 antibodies were sent, and he was started on perampanel and was also given IVIG in suspicion of the autoimmune. So this was over almost 23 days. Then seizure semiology has changed with so many anti-seizure medications. There is a decreased duration. However, he was still having high frequency. Every time he sleeps, these are sleep seizures now. Every time he sleeps, he has 10 to 15 episodes per day. So he was started on ketogenic diet. It was only 2 days into ketogenic diet. So that's when I saw the patient. So now two possibilities are being considered: focal cortical dysplasia and autoimmune encephalitis. So points towards focal cortical dysplasia is all the seizures are stereotypical. There is no change in semiology from one to other. Usually autoimmune, you see some change in semiology. There are no behavioral changes clinically reported by parents or whatever they have observed. No sleep disturbances, no extrapyramidal symptoms. So only odd point for focal cortical dysplasia is sudden explosive onset. They usually respond to some medications for at least 1-2 weeks at least. They don't go on continuously. I mean, that is the usual thing. At least some medication they do respond. Very explosive daily 20-30 seizures is little. We'll have to be careful to say that, okay, this is only focal cortical dysplasia. So for autoimmune encephalitis, that is usually more than one type of seizure, and usual seizures are temporal in nature. Most of the autoimmune encephalitis, we see temporal seizures. Change in behavior will be there, altered sleep wake, at least in 2 months now, it is 1.5 months, some change in behavior and sleep wake cycle should have come up. Extrapyramidal symptoms if thinking of NMDA encephalitis. But the points which is supportive is they do usually have this explosive onset. And they'll usually have generalized tonic-clonic seizures also, at least at some point of time. But this child did not have. So thinking more towards focal cortical dysplasia in view of all these things. Now we'll reanalyze the data. So there is a single type of seizures, and looking at the video EEG, he had 20 seizures. over 2 to 3 days, which was recorded, all have similar onset and EEG spread. The characteristic of EEG and clinical, and also the clinical features in that new on whatever current semiology is, they are all same. They are in sleep, multiple brief episodes currently. So current semiology was arousal. I'll show the videos. It is arousal from sleep, posturing of the right hand, and slight flexion. Posturing of the left hand. Strongly written. Posturing of the left hand and slight flexion of the head, followed by right hand posturing, and there is some change in facial expression, lasting for hardly 30 seconds, and then he recovers. So with this, the lateralization is right hemisphere. Because there is sleep onset, multiple brief episodes, and in the previous seizures he had a gelastic component, probably still in the frontal region, and lateralization remains right hemisphere. So just for gelastic seizures localization, I had removed an article where this is in cingulate, it is anterior cingulate in the frontal lesion with calcification. It was NCC in this particular patient. They had reported 2 seizures, gelastic seizures beyond hypothalamic hematoma. Another one was temporal lobe epilepsy. This is the MTS, but this patient failed surgery. After 1 year, he had recurrence of seizure. So probably they missed actual dysplasia in that patient. So the brain areas most frequently found to have pathological findings in gelastic epilepsy is hypothalamic hematoma. Then other than that, frontal poles and temporal poles. Ictal smiling without the laughing component has been observed in parieto-occipital region, also hippocampus and temporal regions. And some of these Lennox-Gastaut syndrome or generalized tuberous sclerosis also have gelastic seizures. And the EEG will show they evolve somehow and this gelastic component comes up. Smiling. So these were all the just theoretically differentials. So this is the seizure, current seizures. He woke up. Left hand first goes into some posturing, right hand some automatism. Some tonic posturing of the whole body. Then he has recovered. Now he goes back to sleep. So very brief, similar, same events keep on happening. So this is the EEG with this semiology. The onset is here where there is diffuse attenuation. So some even the EEG has changed with the medications. So there is some slowing happening. This is sleep spindle, so this is normal part. Here something has started changing, background is there, and there is this diffuse attenuation starting here. And the whole background has gone into diffuse attenuation with the fast activity. And at the end, we see some alpha range activity, theta to alpha range activity, which is slightly dominant on right compared to left, followed by diffuse slowing. So this is the next page, which is also showing slowing compared to the background. And he is recovering now at the end of it almost. So brief seizures, all of them, just one more seizure to see that the semiology is almost same every time. Arousal, left hand flexion and posturing, some neck flexion and becomes a little tonic. Lifts up his right hand. Then he has recovered. So these are the current semiology after starting treatment, very brief. So EEG is also same. This is sleep, some change in background, followed by diffuse attenuation with fast activity. And at the end, some theta to alpha range activity, which is slightly predominant on the right side. So at this stage, the elastic component was probably likely because of involvement of cingulate, but it is probably a later into the network. Right now, from FCD, there will be a network through which it is spreading. So probably it is spreading to cingulate and causing the gelastic component. Origin is probably not from cingulate, as the current semiology does not have gelastic component after some control which has attained. So lateralization remains right because of EEG, and also there is left hand posturing first which occurs, and also better spikes on the right side. Localization is likely deep seated and spreading to cingulate because by the time we are seeing on the surface EEG, it is generalized. So with this thought process, we thought of right orbitofrontal more than left. So this is a MRI. Actually, I have taken only single picture. This particular gyrus, if we look at this gyrus, there is a clear gray white matter demarcation. But in this particular gyrus, that gray white matter demarcation is gone. If we see closely, these dots are there which are going into the white matter. So this is from TD-T1 sequence. It's not very clear. This dots. Some gray white matter differentiation is lost compared to what we see here, everything clearly. So same thing in the flare, mild hyperintensity and fuzziness of the gray white matter. This is also 3D flare sequence. Actually, initially they had not taken 3D flare and we got it done later. So when we do MRI and PET fusion, that hypometabolism in last sequence which we saw initially, that is over here. I think it's not visible in the screen clearly. I think in the sagittal we can see this loss of this continuity we are able to make out. That same thing we can see here. I can see on my screen, but it is not projecting well. Yeah, this particular area, it's there. So next, when we dull out the PET scan and see at the MRI, it is corresponding to the same gyrus which we saw in the T1 and the flare. So this particular area is not having that red hypermetabolism which is there in the rest of the areas. So thought of FCD, he was given loading with injection phenytoin and was started on oral oxcarbamazepine. And after that, there were no seizures. Actually, at this point, we were discussing whether to go for surgery or do a stereo because he was immunosuppressed, how to go about the things. And we thought we'll give a trial of phenytoin because that's oxcarbamazepine basically, because that's the drug of choice in focal cortical dysplasias. But after that, he has no seizures after loading with phenytoin. So 5 months follow-up, he's on oxcarbamazepine, valproate, and perampanel. No seizures till now. So, not right. Oxcarbamazepine is an oral thing. Perampanel. Right, oxcarbamazepine. So, come case. No risk of worsening by oxcarbazepine. I think it is because one is that it is injectable is not there, and yes. I had kept. I think some slides are missing. So coming to case 2. So this is a 8-year-old girl with the complaints of seizure starting at 3 months of age. Initially, seizure was with fever. That was post-vaccination fever, and there was a seizure at 3 months of age. Later, multiple episodes of febrile seizures. A febrile seizure started at the age of 1 year. That has been going on and off, once in 3 months, once in 6 months. And had GTC, this type of seizures were GTCS, focal seizures, sometimes right, sometimes left. And previous frequency was once in 1 in 2 months. Then right now, she's having only left focal seizures and daily seizures since past 2 months. So because of this change in semiology and increase in seizures, she was referred to the epilepsy clinic. So current semiology is falling to left with the deviation of eyes to right, left hand posturing, both lower limb posturing after that, followed by clonic jerking of all 4 limbs, lasting for 1 to 2 minutes. Postictal weakness was seen in the left hand, lasting for 15 to 20 minutes. So with this semiology, left lateralization with the postictal weakness somewhere near motor area, we'll have to think of. And these are the current, is the day before the consultation, she had 30 episodes. So yes, all these medications before consultation. So she was on for a very long time, she was on valproate and clobazam, but some valproate overdosing happened. She had drowsiness, and then she was on levetiracetam. I forgot to mention that she was on levetiracetam. Later, when this focal seizure started on carbamazepine. So the valproate was stopped, sir. Valproate was stopped. She was on levetiracetam, carbamazepine, and clobazam when she came to know. So, born to non-consanguineous couple, history of one episode febrile seizure in paternal cousin, otherwise no significant history, normal perinatal period. Development was delayed. She started walking at 3 years of age. Currently, motor-wise, she has caught up. But since past 2 months, frequent seizures and falls, she has ataxia issue. I mean, not ataxia, they said she was falling. Clinically, she didn't have ataxia. Fine motor, she's able to scribble but cannot button. She can feed herself. She speaks 3 to 4 word sentences but has a poor vocabulary. Number of words she can use is less. She was in 3rd standard, but now because of daily seizures, she's not going to school. Her scholastic performance was poor. She has difficulty in writing primarily. Examination wise, on the day when they presented, she had normal neurological examination. At least in the OPD, she didn't have any seizures. So interictal EEG, whatever printed was available, showed multifocal spikes. Then MRI brain done at 1 year age was normal. Then recent MRI was repeated, which was reported as a small one sulcal dysplasia in the right frontal region, which matches the clinical semiology. This was reported by Ravarma. So after this history, hypothesis wise, because of the febrile seizures, though the current semiology is focal, EEG wise there was multifocal spikes and poor scholastics and developmental delay. So MRI is showing bottom of dysplasia, but odd points for focal cortical dysplasia is it is a tiny bottom of sulcus dysplasia. So those dysplasias usually present 4 to 5 years after that age. Only larger, at least one whole gyrus is involved, which is easily visible on MRI only, present earlier most of the time. School performance and development is unaffected in bottom of sulcal dysplasias. So it should be at least a lobar type 1 dysplasia for her to have developmental delays and early onset epilepsy. For that, I had repeated EEG, which was not showing any focal slowing. That would have picked up if there is a lobar dysplasia. So points for next thing would be febrile plus afebrile. It has to be SCN1A. So febrile seizures is supportive. Multiple seizure types is supportive. Early onset vaccine induced is supportive. Multifocal spikes can be seen in EEG. Scholastic difficulties are known to occur. And seizure frequency, which were increased, coincided with starting of the carbamazepine. So with all these clues, thought it is more likely to be SCN1A than focal cortical dysplasia. So sent clinical exo, and she was positive with pathogenic variant. So she was carbamazepine was stopped, and she was kept on levetiracetam, topiramate, and clobazam. As a backup, it was given. They had to start it because of the seizures. With those 3 medications, now 1 year follow-up, she had only 1 episode of fever-provoked seizure. She's going back to school. She's good in orally telling the answers, but because of the writing difficulties, she's overall poor in scholastics. ADL, that activities of daily living requires some support. Difficulty in writing is there. So role of focal epilepsy features in SCN1A mutation. So this was a study in 2021. They have looked at 82 patients with SCN1A mutations, and initial state is at the onset of the disease, whereas steady state is after 2 years of age. So during the onset, there were 54% of children presenting with focal seizures. Once they reach the steady state, 90% of them have focal seizures. So Dravet syndrome frequently has focal seizures after age of 2 years. And so we should not get confused with that. And this is focal epilepsy in SCN1A mutations is the role of epilepsy surgery. So these people, they have done seen 8 patients with SCN1A variant and focal cortical dysplasia, and they did surgery for them. So in patients with Dravet syndrome had unfavorable outcomes, whereas where there were SCN1A unknown VUS variant and clinical phenotype was not matching, and there is a proven single origin proper FCD, they had a good results. So if the SCN1A is positive and it is pathogenic, FCD should not be treated as for a surgical listing. They don't usually get controlled. So this is co-occurring malformations of cortical development in SCN, another study in 2014. So in this, they had only, this is about 4 patients who, out of 120 patients, 4 patients had dysplasias reported. In that, they did surgery for 2 patients. Neuropathology revealed focal cortical dysplasia type 1A and 2A, but surgery was not useful. They continue to have seizures. So even if we find focal cortical dysplasia in SCN1A, then it is not a good substrate for surgery. They don't recover. It is predominant. That is, if it is clinically matching phenotype and there is a pathogenic variant, we should not opt for surgery in these patients. So points to remember: oxcarbamazepine is a good drug for focal cortical dysplasias, but SCN1A mutation spectrum frequently has focal seizures at later age, and oxcarbamazepine worsens seizures in them. FCD can be associated with SCN1A mutations, and resection does not give seizure freedom. So always clinical characterization of the epilepsy syndrome is key in identifying the drug of choice, and both of them were drug refractory epilepsy to start with, but now they are not refractory anymore. So appropriate drug trial is key before labeling it as a drug refractory epilepsy. We'll go to the next presentation. Sometimes they do, sometimes they don't. I've seen now 4 patients with SCN1A. Always same side eye deviation he comes with. At one point, even I was tempted that I should start doing workup, but he is clearly pathogenic SCN1A mutation. Somehow they tend to have same side. Yes, yes, at least for a period of time. But from history, you'll get that changing lateralization might be there. Yes.
Sometimes parents don't report, but just that
Not everyone has not everyone has those things. Problem is focal cortical dysplasia is also present with fever provoked seizure. So just febrile and afebrile seizures can still be focal cortical dysplasia. So rest of the things have also been looked at. I think developmental delay is one of the good handles to look at. So that would say that it is SCN1A. So we'll move on to next case. Next case will be presented by Dr. Gauri Shankar.
Good evening, everyone. I'm Dr. Gauri Shankar, second year neurology resident from NIMS. I'm presenting an interesting case of dystonia in a child. So, my patient is a 11-year-old boy, presented with complaints of delayed achievement of milestones since birth, difficulty walking with progressive bending of the trunk for the past 2 years, visual disturbances for the past 1 year. He's a firstborn child to second degree consanguineous parents. He had a normal antenatal and uneventful birth history. The immediate postnatal period was also uneventful. So developmental history, gross motor he achieved in a delayed manner. Like head control he achieved at 6 months. Sitting without support he achieved at 1 year. And standing around 1 year 6 months. He walked at around 2 years, running around 3 years. By 5 years he was able to jump. Fine motor reaching by 5 months. Bidextrous grasp around 6 months. Unidextrous grasp around 7 months. Inside grasp around 1 year and scribbling around 2 years. And language basically he achieved somewhat appropriately, somewhat mild delay was there. And a single word with meaning was able to tell only at 2 years. And around 5 years of age, he was able to tell only 2 to 3 word sentences. And currently he is like 11 years of age. He speaks only in short sentences, but clarity is good. And social milestones, he recognized mother at around 2 months, and social smile around 3 months. Stranger anxiety around 1 year. He was playing with other children only by 4 years of age. He is going to school, but is very poor at academics and sports. He does not read or write. Vision and hearing apparently developed normally. And the main complaint was he started walking abnormally for the past 2 years. Like initially he started with inward curling of the toes of the right foot, actually he developed a bending of the knees while walking, and slowly the trunk also bent towards the left while standing and worsened on walking. This is gradually progressed over the past 2 years. Initially started with only in the right foot. And parents also noticed there was a visual disturbance in the form of difficulty in near vision and frequent bumping into objects. No local eye symptoms were there. He did not have any sensory complaints, no weakness, no bowel or bladder complaints, no falls or swaying, no sudden jerks, no seizures, headache, or no other abnormal movements. On examination, he was conscious, coherent, and cooperative. He had a subtle facial dysmorphism, like he had an open mouth with extended neck. Otherwise, no obvious abnormality which was noted. General examination, he had a scoliosis, which was mild. Actually, when we see the patient on when he was sitting, it appeared to have a severe musculoskeletal abnormality. In fact, he was initially referred to orthopedics for a correction of scoliosis. And they saw there was some odd points, so they referred to neurology. And he had a mild convexity towards the right. And this apparent scoliosis, which was very prominent when he's sitting, actually becomes very mild or disappears when he's lying down on the bed. And his vitals were stable. Anthropometry fairly okay. Head circumference was around 50 centimeter. Eye examination, there was no KF ring. Otherwise, it was normal. Fundus was also normal. No retinitis pigmentosa, no optic atrophy. And examination of cranial nerves, he had everything was normal except for a reduced visual acuity. I was counting fingers at 4 meters. And one more feature was like whenever he drops any object just in front of him, yet he's not looking at the object directly. He's searching for it for some time and then picking it up. And this was like first appreciated by the parents. Which when we tried also, it was like difficult to find the coin which is nearby. When a little bit more distance around 1 or 2 meters, he is able to identify. And motor examination, bulk was normal. There was no atrophy. Actually, like when checked visual acuity, was like counting fingers at 4 meters. Beyond that, he had blurring. So we thought he had a like refractive error with a distal vision impairment. But again, during the near vision also. No, sir. No. Only that when you drop object nearby is not able to pick it up. No, sir. Extraocular movements is normal. No obvious impairments. No diurnal variations. It's like progressively increasing for the 2 years. No fluctuations or variations. Specifically, we were not able to pick up. Like we were thinking initially, history-wise, I thought like a near vision impairment because he had a difficulty reading, he had difficulty writing. Along with that, he had difficulty in picking up object nearby. Yes, 4 meters. Yes. Yes. Beyond that, he was again having blurring. And tone, actually, the lower limbs had a rigidity, like left side was more than right side. And he had a prominent dystonia, like there was a cervical dystonia, there was a truncal dystonia, he was bent towards the left side and had a limb, both upper limbs, both the lower limbs, as well as hand dystonia, which is more on the left side. In fact, dystonia and more on the right foot as well as in the left hand. And power examination, upper limbs was, he had a normal power, and lower limbs he had a mild proximal weakness. The hip flexion was 4+, was not very significant, and other muscle groups are normal. And his reflexes are normal in upper limb, was slightly brisk in the lower limbs, and plantars were flexors. Sensory examination, he had a normal sensory examination. His coordination was normal. He did not have any meningeal signs. Skull and spine, he had a scoliosis with convexity towards the left side. And he had mild Achilles tendon contracture, which was bilateral. And the system examination was normal. Normal on both. Like he did not have any obvious intention tremor or overshooting. Sir. Yes. 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 So this was the pedigree chart of the patient, and he was born to around 3rd-degree consanguineous parents. The first child, actually, there was an intrauterine death at 9 months. The second child, he is the second child, and there are 2 other children. One younger sibling, younger male sibling, and one female sibling. Both are normal, compared. They were developmentally normal, and they were going to school and doing well in academic and sports. No other family member is affected. Clinical syndrome. He has a developmental delay. By this time, you can categorize as an intellectual disability with chronic progressive generalized dystonia. So, dystonia visually, yes. Just this was the clinical picture of the patient. The way he was sitting and the way he was standing. Here, actually, he has a laterocollis along with the torticollis and a mild antrocollis also. And the upper limbs, if you see, the left hand has more posturing compared to the right, and in the legs, actually right legs, the toes are incurling. So this is how we presented. This is how we presented to us. Like that's why the outside practitioner initially thought was severe kyphoscoliosis and referred to orthopedician. Yes. There was a component of refractory errors, definitely, because distant vision he was unable to see. We were clearly seeing it was blurred. Up to 4 meters only was seeing. The near vision, initially thought there was a down gaze palsy, but extraocular movements was unimpaired. He is able to see in all directions. Field defect is one possibility. While sitting is slightly better. When standing, while sleeping becomes straight. Even sometimes if he's not anxious, he's sitting straight. And whenever we ask for some activity, he's having this bending. And sitting and walking also there was significant difference. While walking, he bends even more. So the initial provisional diagnosis, it's like a childhood onset progressive generalized dystonia, involving all regions, like both the legs, right more than left, truncal, as well as both the upper limbs, as well as the neck. Even the possibility of persistent jaw opening, which was there, also there could be a possibility of oromandibular dystonia. So initially, we thought of possibility of Wilson's disease, NBA spectrum disorders. Could be organic acidemia like MMA or propionic acidemias. Again, there was no episodic worsening, and the possibility of mitochondrial disorder was also entertained. And neurotransmitter disorders like dopa-responsive dystonia and other primary genetic dystonias were our initial thought, provisional diagnosis, differentials. we did not consider acquired cause because 2 years there was no acute insult and he was chronically progressing, and there was a consanguinity also. Nothing, no perinatal insults. Till 8 years he was fine. Baseline, he had a baseline development delay, predominantly motor. And the school also he was not doing good. Onset at like in the first decade, it could be even like PNK, like Halavirus causes one possibility. Yes. Intellectual, yes, significant, preserved, yes, yes, sir. And Wilson's disease also first. Yes. Yes.
But they generally have more of Parkinson. So they have the present intellectual, but second decade, they have Parkinson. Dystonia is actually not that, but that's only the present later.
Yes. And Wilson's disease again, like since it's very common, and definitely we have to rule out so the treatable disease also. And, but significant generalized dystonia at 8 years of age is without any other manifestation is somewhat odd. Sir. Like yes, sir. Cautious. Yes. I don't investigations. Yes, because intellectual disability preserved. Yes. Sometimes even the other degenerative disorders like spinocerebellar ataxia, which can some of the variants can present with significant dystonia in the first or second digit. Another possibility. So investigations, all his routine investigation, blood investigations were normal. He had a normal calcium, magnesium, phosphate, normal thyroid function. CPK was 170, it's normal. And NCS was done, which is normal study. And routinely, we wanted to rule out yes. 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 Actually, yes. This actually the NCS we wanted to rule out a peripheral neuropathy. Some of the disorders like mitochondrial can be yes. 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 Actually, MRI brain and spine was outside. He came with the investigations. MRI brain was put as normal, and spine there was a moderate root compression of multiple lumbosacral nerve roots, and there was disc bulges which was there anterior and posterior in the lumbar region, and his vitamin B12 and folate levels were normal. And investigations, routine IQ assessment was done outside. Like they reported a 59% IQ score, which is like a mild intellectual disability. Ophthalmic examination was done, was not suggestive of any KF ring, and fundus was normal. And ultrasound abdomen was normal. Wilson's disease workup, ceruloplasmin, copper, urinary copper, everything was normal. Actually, TMS DCMS was not done. Like genetics was done, sir. Like,
So you can treat as a possibility of
for a whole example, like, yes,
in the sense you have only artificial examination.
yes,
Yes.
yes.
Is that true or is it just clear this one but balance to the abnormality? And then MRI spine.
So for MRI spine,
Yeah.
MRI spine, moderate root compression, sir.
Yeah. So
No, sir.
is that significant?
It is significant. It is significant because
So because if that is the legal finding of this difference, so radiography look at something else. That might be your biggest standard for the genetics.
yes,
Okay, so that's why you have to say at that point only that is not significant or significant.
yes. MRI spine actually in a pediatric age group we don't expect disc bulges and root compression. Sir. Dystonia. That's what we.
So the person who does a lot of weightlifting, lot of sports activities, they cannot have the discs. Doesn't matter the age.
Yes, sir.
These sports people are not that of discs. Okay. So here it's like exercise power.
Yes.
So this severe bumper dystonia.
Yes.
So that might be this possible discs.
Yes.
Okay. So that's more probably that is the reason that not be
Yes. Okay. And patient was actually given a trial of levodopa, like which was gradually titrated increasing doses, but there was no significant response. And yes, a whole exome sequencing was done.
So
Yes. Yes. Yes, sir. I have, sir.
what point of
Imaging was like 1 year back it was done, sir. 1 year back it was done. 1 year into the disease. It's not clear. Actually, MRI, I mean, CT was done and MRI was done. It was somewhat old images, the films were not affected. CT was normal, there was no basal ganglia calcifications, no hydrocephalus, no obvious anatomical abnormality. There was a posterior fossa cyst is there. Actually, it is like a, without it, a posterior fossa cyst we thought. Inferior vermis epilepsy, yes, possibility of inferior. Yes, yes, sir. Otherwise, the basal ganglia structures look normal, sir. Corpus callosum developed normally, gyri sulci pattern, everything looks normal. This is the MRI spine, sir. Here we can see the looks fairly straight compared to how he looks. There is mild scoliosis which is there for the convexity towards the left. And here we can see the anterior and posterior disc bulges and significant disc protrusions are also noted. That could be explained by his severe truncal dystonia. Yes. But some wedge compression of the vertebra is also. So the whole sequencing was done. It came pathogenic, likely pathogenic for a homozygous variant in CBS, cystathionine beta synthase genes, suggestive of homocystinuria. So the other genes were not significant because this was like a muscular dystrophy which is not clinically fitting in this case. So we did not take it significant. Another one is also not significant. And the last methyl malonic aciduria and homocystinuria, again, it's a heterozygous autosomal recessive. Even though it's pathogenic, we're not taking it significant. So the first mutation, we are taking it as significant. And actually, after this genetic report, when we asked for the patient's follow-up, when you called the patient, he told he's in a Aftal hospital actually. I asked why he went. He sent me a photo of the patient. Actually, he developed this after 4 weeks. Yes. Lens got dislocated anteriorly. This was not there before. And Yes, that video is very clear. Actually, in fact, when we came again, we asked for a follow-up, and we sent a homocysteine level which is like more than 65. Like that's the maximum limit we have, and give the value as yes.
So they can increase the dilation specifically because you need to know the baseline. You might be starting at 150 when you start the treatment. But if you have only more than 65, you don't know what the treatment is responding or not. So you need to ask them to get the machines.
Okay. And this is here we can clearly see even the other side lens is also dislocated. Generally in homocystinuria they say typically it's inferonasal. Here it's somewhat temporal. But here we can see clearly the margin of the lens which is dislocated. And the right eye actually the dislocated lens actually caused probably anterior. I mean caused a compression and causing glaucoma. There is redness of the eyes. He had severe periorbital pain. That's why they had to immediately admit and operate. So the lens was removed and currently is doing well. So final diagnosis like a homocystinuria presenting as a childhood onset generalized dystonia. It's like very homocystinuria is described to have a dystonia as a presentation, but very odd to have a generalized dystonia. And literature search we did there we found there is like cases which has been described previously with generalized dystonia, like 3 cases. It was actually a very old article, 1988. There's 3 homocysteinurias, all are CBS mutations. And fortunately, this patient did not develop thrombosis, and has been put on a high dose of pyridoxine. And this was a case of homocystinuria with dystonia and stroke. In all these cases, they have tried to find out why this homocystinuria patient is having dystonia. They don't have obvious basal ganglia abnormality, even atrophy or anything. And more looking like a functional effect. And in this article, they mentioned the possible hypothesis like the patient had a stroke. Left side water take fuck was there, and they suggested a possibility of the connections, basically connections could have been involved, and patient has a dystonia. But again, it won't explain the generalized dystonia in this case. This vertebra I stressed on the MRI span because the disc bulges and the wedge compression collapse is very actually one of the skeletal manifestation of homocystinuria.
Actually, he came to the last week.
Yes.
That's the optimized for very high systems. Because would help selectively. Homocystinuria, so I don't see colon. So we just started that along with few other mutually and other supplements, 3 days supplementation. So that helps. So we added all of that. So this last
So this treatment is into like 4 weeks of treatment now. We got a homocysteine again. We got a value like more than 60. We hit the titrated.
So this case actually I need more inputs from one of you. So this is an interesting case and some. So yeah, so he's a 13-year-old boy who came complaints generalized body pain since 3 months and fever on and off for 3 months. So these are the various timelines where he required admissions in various other centers as well. So it's released on 3rd of July with complaints of generalized body ache since 5 days and headache for 5 days. And he also had fever on and off for past 10 days. So he was worked up for dengue, which was negative, and also counts were low initially, but rather improved after in a span of 4 days. And his vitamin D was low, and his CK levels were rather on the higher side. And he was managed as acute viral myalgia, and he was discharged. After post-discharge, he was rather improving in a span of 4 to 5 days. But after a week, he developed again severe pain in the calf muscles and thigh muscles, along with pain in the arms and forearm muscles as well. That and also involving in the lower back as well. The only spade areas were in the upper back and the chest and the abdomen. Even neck muscles also got involved, and the pain was so severe he was not able to walk properly, and gradually he became bedridden in a span of a week. He also developed joint pains, mostly involving knee, ankle, elbow, and shoulder joints as well, and also small joints gradually got involved. He had proximal weakness more compared to the distal weakness, and there were and he also had pins and needles in the all throughout the body, and he has involuntary movements which are rather varied in frequency and amplitude all over the mostly in the lower limbs, and his body is excessively stiff, mostly in the arms and the back, and he also had a history of recurrent shoulder dislocation 2 years back, and in past 1-2 months he had once or twice his shoulder got dislocated spontaneously, and he also had a history of autonomic dysfunction in the form of not able to sleep properly and intermittent fever and also excessive sweating as well. There was no any history of myotonia, contractures, or rash. So then in the workup at this time of admission, his counts improved and the CK also came down. His panel for the messages came as negative, and it includes all these antigens, including all those were negative, and ANA blood test also was done, which came as negative, and his NCV was done to look for any neuropathy, which was normal, and his EMG was not suggestive of any denervation potentials initially, and his ferritin was normal, and his MRI of bilateral upper limb and lower limb was done, which was normal. He was being managed as myositis, which and he was given pasteurized for 5 days, and he was discharged on diazepam, gabapentin, Ometa-Q7, and PCM as well. So this is a video of the child after 1 month into the illness, and he is having this involuntary movements that is very painful for him. By this time, he was actually bedridden, and he was not able to move all over the body, and he was not able to sit also without any support. All over, both legs, yeah, mainly limb also. So we have a child with myalgia, polyarthralgia, intermittent fever, with stiffness of all over the body, mainly in the back and arms, with involuntary muscle twitchings and paresthesias and autonomic instability. So initially it was so he had excessive sweating he had, and on and off fever was present, maybe due to the myalgia, that we are not sure. And also he had he was not able to sleep properly, and that was not documented. Actually, he was in various other industries, but it was not documented actually. Nothing. Yes, sir. Sir, in sleep also is not able to sleep properly. He's having persistent pain also. Initially, it was thought it was thought as functional only, but the child was not able to improve. The mind is there. Even sir, even what the video, even this one video actually that we cannot see actually. Even when we're touching also, there's some mild tremors kind of we can feel actually. Sleep also, that moments were not there in sleep.
Severe insomnia. Had recent case which
Also was thought of like more than
it also modified the dominant symptoms. Tendency to consider it is not functional.
for the cost, man, what was the cost for the moment?
Casper antibodies. The person of hyperexcitability.
Yeah,
But that patient gave and severe failure, we just ignore it. Yes, that's why they're on my this is very
But he had mild and all his other actually. But it was actually initially, but later on we found out that they thought of dermatomyositis and also, but the child didn't improve after that also. No, he was not able to sleep properly. According to mother, she was very much no. Yeah. Spikes were there, not one or two. Again, it will come again. It will come. So initially it was thought of, well, TRP was positive sometimes and negative sometimes. Not very high. So it was thought of as like Morban's or Isaacs or even Stiff syndrome also. And on the order, we even thought of some kind of metabolic memories as well. So then in 1st of August, he again presented in various other center. There it was worked out. His CK became normal. His workup for the RF came as negative, and his PET bone scans suggest of arthritis, increased uptake in the sacroiliac and hip and knee joints, which suggest of arthritis, and the workup for the metabolic came as normal, and his biopsy was normal. It was there was no any inflammation and no prevascular atrophy and all, and was usually low, but became normal later on. And the one thing is he had hyperuricemia. It was 10 initially, but came down to 8.6 on febuxostat. His spine was normal, and his ANCA levels also were normal. Was there for him, but the cause not sure. Von-Gilkes can have, but his biopsy would not reveal anything. It was not done. TMS was done, but genes we didn't go until that extent. His VGK also was negative in the serum. So this is the video. Of the time that is the. There's some mild movements in the myocardia kind of. Casper was negative only. So he was started on oxetol. After oxetol, his pain improved in the upper limbs, and also the tremor also got decreased. And then even psychiatrist was taken, he was going to gabapentin, dosage and all, but there was no proper response. And GAD was negative, and CSF PGKC also came as negative. And CSF protein was normal, and EEG showed phase reversal, and EMG showed fasciculations. But I think here it was missed. I think so. Micromia was not able to record. I mean, I'm not sure actually. It was done outside. Here also we had done, but here we found micromia was present here. Then in your double negative autoimmune etiology, he was given IVAG 2 gram per kg, and also pulse again was repeated. But despite that, the child did not improve, and he came to us. And so, what is the next that we can give for the child actually? So that's what I want to ask. Either we can go for Plex or. So cause is not known, the main thing. Pregnancy. Bone scan, PET scan. So I. So in this case, actually, after seeing certain in the literature and all, it was found that heavy metal, poisoning can lead to Moorman's kind of syndrome also. So in this case, aluminium was very high. It was done on 15th of September, and nickel also was very high. But there are reports of causing mercury, lead, and silver. But there are no reports. Of aluminium causing those Moorman syndrome or some depressive syndrome, but was not reported actually. They are known to cause, but what metals they are reported only, I think mercury, silver, and lead only. But, he had history of homeopathy, but not Ayurvedic. That on probing that mother was telling that. But homeopathy medicine, I'm not sure whether it will cause mental poisoning. So after this, the mother was so much depressed and she didn't turn up. And again on 1st of October, we repeated the level. It was very high. It was 1400 actually. The levels kept on increasing. And now actually the patient is in ward and is police actually which reports that it was reported causing all after Siddha or but after homeopathy there were no proper reports. So now he's in ward and he's undergoing dialysis and all. It's actually today it is second cycle. So we have to plan to repeat after 2 cycles of the aluminium. I think the filter is being used, and probably I think we need to see. After that it will come down or not. No, that's what I'm not sure, because it was stopped actually. It went for 2 months and it was stopped, but it kept on increasing despite giving IVAG and source as what can be the that medicine that she had given in past 2 months or so, but that I have seen that, sir. I have seen that. Yeah. Yes, sir. It's a prior to that.
Because in fact, the first person means like the neurologist was very good examination.
But mother, so here she is very much caring about that. But here the mother is actually very much caring, sir. But that is not the case, because he was not even, I mean, lifting calls also for nearly, I think, 2 weeks. Then finally she came and then we had so hair, nails and urine. The tablets also who were sent to NIMS on daily, they do no checking and all the medicines. The medicine what actually in the literature it was
because sometimes insomnia
but very high levels of aluminum as well. Like 10 only is like 1400. We'll see. I think after that, I don't know. It's like a dilemma actually. I have one doubt. Sir. Can 2.5-year-old child have DMD? I mean, he had only connected jaundice actually. I mean, only bilirubin, only I think AST, ALT were high, and he was actually worked up for liver causes. I mean, that all came as negative. Then finally, I mean, the exome sequencing it turned out to be DMD pathology variant actually. Now he has no symptoms as of now, but
it's such a criminal mind. He was a pharmacist. Now yeah.
Sure.
Yeah, I'm Dr. Praneeth. I joined as a pediatric neurosurgeon at Rainbow with Dr. Lokesh and team. So I'm from Hyderabad. I completed my MBBS from Osmania. And coincidentally, I have one of my batchmate here, Dr. Dinesh, is assistant professor at Gandhi Medical College. Then I did my MS from AIMS, Delhi, and then MCH and postdoctoral fellowship from PGH Chandigarh. The last 4 years, I was working as a faculty at AIMS Delhi. And yeah, so I can help you out with all these procedures from hydrocephalus, brachial plexus injury, spinal dysraphism, scoliosis, deformity, vascular, CVJ, brain tumors, spine and head injury. Coming to functional neurosurgery, listening to you guys, I think I might be jobless, but still then, if you find me of any use, I can help with epilepsy surgeries, dystonias, pallidotomies, TBS, selective dorsal rhizotomy, syncretical baclofen pumps, drazotomies, chordotomy, spinal cord stimulators can be tried for pain, intractable pain. So as all your neurologists, you will be very hungry for some knowledge. Just to share regarding that patient with dystonias, with degenerative spine and some scoliosis, we happened to see last week. So to add on, whenever there is degenerative spine, it is never the fault of the spine or the forces, but it is weak muscles behind. Even if a young patient, without training of muscles, you try to put constant pressure or forces, then you will have degeneration. Very evidently here, the muscles are weak and they are never to be trained in a proper way. So they tend to have degeneration. And that patient was going into from straightening of lumbar curve, maybe towards lumbar kyphosis. The second thing is the scoliosis. This kind of scoliosis is called neuromuscular scoliosis. This has a high tendency to progress. Once you have curvatures of more than 20, when compared to the idiopathic scoliosis, they tend to progress more. And the second peculiar thing is idiopathic scoliosis after skeletal maturity of 16 to 18 years, they hardly progress. But these patients do progress after 16 to 18. They have got bad angles with pelvis. They can be associated with hip deformities and also require surgeries for hip along with the spine. And if patients genetic workup has a good kind of a lifespan, they can be offered spinal fusion if identified early. Only catch over here is if you identify it at younger, at a smaller angles like 20 degrees, 30 degrees, we can try bracing. And if we once we cross the skeletal aging, we can expect them to just go out with the bracing. But once they touch 40s, 50s, they tend to get to bad curves. And those curves will be very difficult to treat, and it will be always a suboptimal work when you treat huge curves. It is short. We didn't share the slides.
Reshma is also there. Reshma, any questions?
No. Yeah, hi, sir. Actually, I was just wondering about the toxin-induced, myokemia and all that without any toxin exposure and things like that. And I was keen on knowing the EMG and autonomic function test findings in that patient.
Yeah. Autonomic functions were not done. EMG, there was this one, denervation findings were there.
All right. Thank you, sir.
Kirti? promise. You.
Support. Hi, this is support team. Hello. Hello.